everyone. This is the Shelbourne Knee Center podcast. This is Dr. Benner here with Scott Bauman, and today we're going to be talking about next part in our patellofemoral instability, patellofemoral dislocation series. This is our fourth episode of this series, and last time we talked about surgical technique for patella realignment surgery. If you haven't listened to that one yet, a lot of surgical pearls for the surgeons in the group, and today we're going to pivot to rehabilitation for this group and talk about how do we get these patients back, how do we avoid surgery, and if we end up doing an operative procedure, how do we move forward from a therapy perspective.
Now, I may be a little biased with this because we're talking about a rehab topic with me being a physical therapist as well, but we're going to have Bill on today, and he was on for our rehab after contralateral ACL reconstruction episode. So we're excited to have Bill back and talk about this topic. Bill, welcome to the podcast again.
Happy to be here. Thanks for having me.
Now, just as we started off when we talked about the evaluation of these with Dr. Benner, I want to ask you some similar questions when it comes to the evaluation. So first and foremost, how often are you seeing these from a rehab perspective?
Yeah, so as Dr. Benner pointed out in one of the prior episodes, we're seeing this volume of patellar dislocations much less frequently than we are with our ACLs. So, it's kind of like a 10% mark that we put on it. So for every 10 ACLs, we may see one patellar dislocation. That volume may have increased a little bit over time just with more year-round sports and exposure to injury, and we're kind of seeing things happen a little bit more often. But again, it's one of the less common things we see in the office, especially when we compare it to our ACL volume that we see.
So, Bill, when you see these patients, what are some common things you're looking for with your initial evaluation of a patella dislocation patient?
Yeah, in our office, we're as the PT, we're actually really fortunate to be able to first one to take a history from the patient. And that usually will guide us down a path of considering patella dislocation as one of the differentials. So we do a really good job of trying to get patients in quickly after an injury. If they call and have an acute injury, we can get them in pretty quickly. And then they have a pretty good recent memory of the history of their injury. So we go there with, is this a big deal injury? Did you have something happen? You went from being normal to not normal in an instant, not something that you could return to play right away, run off on the sideline. Sometimes it's pretty urgent where they might seek urgent care or an emergency department. When we see them in the office, then if we're starting to think that way, we're looking at, have you ever had a prior injury like this to this knee or the other knee? Because as you discussed in the classification system, we can have patients who have congenital anatomy that predisposes them to prior patella dislocations. So some patients may say, yeah, this has happened to my knee a couple times. We look for things on exam like J signs, but then we start working them up with x-rays. We're certainly interested in their x-ray views compared to their opposite knee and alignment things with lateral x-rays for patella height and merchant view x-rays for their patella position compared to the opposite knee. And those are kind of the initial workup parts. But certainly the history is a big key component of that.
And Bill, does the history Is the history different depending on whether it's a patient's first time dislocation or whether they've had multiples?
Absolutely. The first time dislocators seem to come in urgently. They went from, again, being normal to not normal pretty quickly. It's very painful, knees suffused. They can't really weight bear. They might be immobilized. It seems like if patients have had prior dislocations and then they dislocate again, especially if they have those type 3 and 4s that you described in an earlier episode where it may not be quite as traumatic. They can reduce the dislocation on their own. They don't get quite so swollen. They can still bear weight. So those patients look quite different in initial evaluation from the acute first-time dislocators.
Now let's stick with the first-time dislocators, the one that you're seeing for that first-time injury. And with the presentation, it seems like they're going to be more swollen and just acutely flared up. What type of rehab exercises and things are you looking to address in that acute time period?
Really, we try to address things with any of our acute knee injuries. I mean, if they arrive with weight-bearing restrictions or they're not putting weight under the leg, if they're immobilized, they're on crutches, the knee has a big effusion from a recent injury, they're definitely going to have stiffness, they have apprehension of movement. So we kind of address those things pretty consistently, whether it's an ACL tear, a patella dislocation, any of those kind of MCL injury, isolated MCL injuries, those big three that we talk about. We work on an effusion, we work on extension first. Dr. Benner had mentioned in a prior episode, one of the differences on exam or presentation we see with these patients is they can get their knee straight pretty easily. So when I bring a patient back and take a history on them and get them on a treatment table and we're trying to start to examine their knee, if they can have their knee lay flat or if we can get them into any kind of past straight extension, I'm already starting to think more patellar dislocation than ACL. So from a rehab standpoint, Scott, to answer your question, we're working a little bit more on leg control and a fusion to help their flexion versus with like an ACL, we're working on extension to get the ACL stump out of the way, get it to the point where they can actually get their knee to go straight. On these patients with patellar dislocations, they just don't have that problem. It's really uncommon to see somebody who can't straighten their knee with just an isolated patellar dislocation.
Now, sticking with these first-time dislocators, and your plan is non-operative treatment, so you get these from the docs, and they're deeming it as a non-operative case, and they're not discussing surgery at this time. When you're progressing them with their range of motion, their leg control, what does that timeline look like when you're progressing them from that acute time period to more of the intermediate and late-stage rehab?
It can be a couple weeks, just like any acute traumatic injury. The body really ramps up the inflammation from the injury itself. So again, normally we try to get these patients into the clinic. We have, see them as quickly as possible. So we may see them within a couple days of their injury itself, and then it may be 2 weeks before we see them back. So during that time, again, fusion control, leg control, gait training, not really working a whole lot on an extension, not really working a whole lot on flexion or leg strength or anything like that. So in the acute phase, it's really just, can we get them back to kind of normal looking with gait and calm the fusion down that they created. And that should really restore a lot of range of motion, just make them feel more comfortable, especially if this is going to be a non-operative case or we're going to make a run at non-operative care for the time being. Those are the early goals that we have for these patients.
Now, let's assume this patient is an athlete and wants to get back to some type of sporting activity. What does that look like for you when you're hitting that late stage in the rehab process? What is your criteria for getting these patients back to sport? What does that timeline from injury look like? And is there anything specific to this population with patellar dislocations that you look out for when it comes to return to sport?
Yeah, so the return to sport criteria, again, is very similar to our return to sport criteria for any injury or any surgery. There's safety concerns of, can I hurt myself again in the same way I hurt myself before? And then there's performance concerns of, well, if I can play, am I going to be as good as I was before? So, we always follow a knee symmetry model for range of motion, no effusion, good leg control, normal gait, equal quad strength. We use a 10% side to side with isokinetic testing in our office, isometric testing, or any kind of hop testing that we might do. If they can achieve those things, then we really start to transition them back to practice. First, solo isolation drills for whatever their sport is before moving them to competitive practice, and then eventually to scrimmage type scenarios, and then games. And then we have to watch the scheduling of return to sport with the patient, so that if they practice or play on a Monday, how do they feel and look on a Tuesday? So it might be a reduced schedule of every other day, every third day, those kind of things. But really, if we're going non-operative care and they've achieved normal range of motion, no effusion, normal strength, we let them progress back to sport pretty, as quickly as their knee allows them to get back to that level of intensity and frequency.
What's that timeline look like, Bill, from the time they come and see us, if we see them within a couple of days of injury, to return to full sports?
Yeah, if these patients are non-operative where there's not an indication to do any surgery on them, it's probably more like a 4 to 6 week time frame. The first couple weeks is going to be just getting that effusion down, getting the motion back, getting them walking normally. That usually takes a couple weeks. And then if we see them pretty quickly, they don't lose a lot of strength because we don't restrict their weight bearing, we don't brace them. There's not a big period of atrophy or disuse that they're going to go through. So the recovery time for that patient, can be as quick as 4 weeks. 4 to 6 weeks is probably pretty typical for that.
So let's move on to those patients who do end up having surgery. We talked in the last episode about what the different options are. It could be as simple as a scope for loose body removal, something like that, all the way up to tibial tubercle osteotomy, realignment, all those. And we kind of talked about those individually last week. Medial side, retinacular imbrication and lateral retinacular release as a soft tissue proximal operation. And then for people that have predisposing anatomy, coupling that with tibial tubercle osteotomy with either distalization or medialization or both. So talk about the early postoperative time period for each of those and how you can compare and contrast them.
Yeah, so the soft tissue only repairs, so that would be the medial imbrication, lateral release, where there's no osteotomies performed, there's no bone procedure involved. Those patients do really well pretty quickly. I've almost gotten to the point now where we're kind of treating them like they had an arthroscopy only. I mean, we can really progress them based on as quickly as they're allowed to progress. So they're immobilized for a period of time. We have our patients spend the night in the surgery center to get some benefits of what we can do there. They go home, keep their leg elevated for the first week. These are for all three of the surgeries that we can do. Put them in a CPM machine, keep a cryo cuff on their knee, work on leg control, work on flexion. But the soft tissue only repairs really can progress as quickly as they're able. So they're immobilized when they're walking for the first week, but those are the group that really get out of the immobilizer pretty quickly. So it might even be after that first visit or at that first visit, a week after surgery, we're working on gait training without the immobilizer on. If they have leg control difficulties, we'll keep them in the immobilizer a little bit longer, but on average, the soft tissue, medial imbrication, lateral release, surgery patients will recover and get out of the immobilizer within the first 2 weeks. Then it's just a matter of getting the effusion to resolve enough where they can have a full flexion in their knee, and then it's on to strength training. So again, I kind of treat those patients like rehabbing a scope, where there's not really anything that's holding us back from letting them get better as quickly as they're able. So we kind of put them through that process. And again, even with that surgery, it's almost the same time frame for those non-operative patients, where it can be 4 to 6 weeks. I know that sounds pretty quick, but I've had patients, if we see them pretty quickly, they have surgery, they don't atrophy much, they can get normal range of motion and be testing with good strength even 6 weeks after a soft tissue realignment.
And I think that's important to keep in mind about that specific surgery is the relative quick progression that some of those patients go through compared to how long the non-surgical treatment plan takes. That definitely comes into our surgical decision making when it comes to first-time dislocators. Are we going to go ahead and do a surgery on them or not? We do keep in mind when the patient's next sport is, what their best sport is, whether they want to return competitively quickly and on what kind of schedule. So if we have somebody come in that is, 2.5 months before the start of a season, and they're maybe going to be a senior in high school and they want to play collegiately, then we're kind of left to balance. If we go ahead with non-surgical treatment, is that going to take 4 to 6 weeks? If we just do an imbrication and release, is that going to decrease their risk of redislocation and not really lengthen their recovery period very much? And I think that's a real, this is getting back into the surgical technique thing, but I think that's a real pearl that really separates that from MPFL reconstruction, for example. I think MPFL reconstruction, we don't really do that, but for people that do, I think the patients who would be most appropriate for that would be the same kind of patients that we do the medial imbrication lateral release on, the people that don't have predisposing anatomy and you just want to reestablish connection to those medial soft tissues to tether the patella to keep it from going out. With MPFL reconstruction, that's going to be the end of their season if they only have a couple months left before their last season starts. So I think that's an important thing to keep in mind as it relates to competitive athletes and what their return to sport timeline is going to be like.
Sticking with the timeline conversation, let's move to the more bony procedures. We're talking about the triots and distalizations now. And to go back to the surgical technique episode, this is the one where a patient would need to medialize the tibial tubercle, which would be a triot. And then if the patient was showing to have a higher than normal patella or patella alta, we would distalize those patients. So, Bill, can you speak to that timeline? You've talked about as quickly as 4 to 6 weeks for the soft tissue medial imbrication and lateral release procedure. But what about when you start doing the bony procedures and start moving the tubercle? How does that change your timeline, not only in the acute and intermediate phase, but also when it comes to return to sport?
Yeah, these patients definitely take longer, mostly because we have to kind of respect some of the healing of the osteotomy that was performed. I would say that the triots, we feel more comfortable with getting them moving a little bit more quickly. I know, Dr. Benner, you described that surgical technique on the last episode, and Dr. Shelburne has described it's almost like you're pivoting the tubercle as opposed to completely detaching it, and like we do with the distalization. So we've been able to move those patients a little bit quicker. We don't really limit their flexion in the first week like we do the distalizations. And so we do a lot more two tolerance exercise for flexion on the Elmsley triot procedures. We feel comfortable with the fixation that you guys perform when you do the surgery, and they can get out of the immobilizer as soon as they have good enough quad control that they don't feel like their knee's going to give out and buckle from underneath them. So in the early phase, Scott, we continue the same routine for all three of these. That first week, the triot patients will restore flexion that's better earlier than the distalizations. They typically have better leg control where they can fire their quad, do a straight leg raise. We get them to the point where they can lift their leg without a lag, or ideally we want them to do an active heel lift where they can fire their quad, pop their heel up off a treatment table, and that's our criteria really for starting to evaluate if they can wean out of the immobilizer. The distalizations, where the piece is completely cut free, moved, placed, and fixed with the hardware, were, as Dr. Benner described it again on one of our prior episodes, we do limit their flexion in the early recovery period just because it takes a little bit more to heal that osteotomy and heal that bony piece in place. So we have to slow down the flexion. We don't let them go to tolerance. It's more like a 90-degree limit the first week in our CPM, and then we can progressively increase their bending on the subsequent weeks. So the TRIOP patients might be in an immobilizer for 2-3 weeks. These patients might be in an immobilizer for 3-4 weeks. The other benefit of how our clinic operates is we're getting x-rays on these patients pretty routinely in the early recovery period. So we'll get x-rays at 1 week, we'll get x-rays at 2 weeks, we'll get x-rays at a month, we'll get x-rays at 2 months. And even before I might see that patient for a therapy visit, I'm getting x-rays, I'm meeting with Dr. Benner and Dr. Shelbourne, reviewing the healing of the osteotomy or with the distalization or the TRIOP procedure, and we're evaluating how that approximated bone is healing, and that helps give us some guidance on we need to slow things down. Still, we're not happy with how the healing looks on X-ray, or if we feel pretty comfortable with the fixation and the healing, where we can start to let the patient do more.
Speaking of doing more with these patients, let's talk about the intermediate stages of rehab. So now we've gotten these patients where they're out of their initial range of motion restriction period. They've gotten out of the knee immobilizer where they're walking without any kind of assisted device or any restriction on their range of motion. What becomes the focus at that point?
Yeah, once we're past the stage of concern for healing, then we can really progress them on flexion-specific exercises. As we've mentioned before on an initial examination, these patients don't really have trouble with extension. So, that's sort of a maintenance exercise during the post-op early and intermediate period, but the flexion is really the focus of kind of that early intermediate stage. Once the knee has normal range of motion, then we're putting them on our isokinetic machine, we're testing their leg strength, and we're giving them a progression of single leg strengthening with the goal of getting that involved side, the surgery side, within 10% of the opposite side. So, those are kind of the intermediate goals: is return the knee to normal, equal to the other side. This is pre-return to sports or pre-return to sport activity. That's what I would call more of the kind of the late phase.
Now, as you move into that late phase, and I know you mentioned about returning patients to sport and what that criteria look like, staying with the timing, how would you answer the question of return to sport time for the patients that are undergoing each of the 3 surgeries, whether it be the soft tissue medial imbrication lateral release, the TRIOP, and then lastly, the most invasive distalization? What's that look like in terms of months?
Yeah, the soft tissue only procedure, I'm writing goals to try to get them back to where they can participate in sports or be normal enough to participate in sports maybe by 6-8 weeks after surgery. For the TRIOPs and distalization, it's more like 4 to 6 months after surgery, just because we have to slow them down in that early recovery period, and then it really delays the return of flexion and it really delays the return of leg strength. So, it takes longer just because we have to slow everything down from the beginning and respect the healing. So that's more along the lines of 4-6 months versus 4-6 weeks.
Now, this is more of a hypothetical question, but if you had a patient that had, for example, a TRIOP procedure where they're medializing the tibial tubercle, and they were not able to reach that goal that you had of the 4 to 6 months of return to sport, is there a pretty common culprit? Meaning, is a patient that may take 7, 8, 9 months to get back to sport, is that mainly because they're lacking quad strength, they're lacking confidence, it took them 3 months to get their motion back instead of 2? Is there anything that you see on a consistent basis, or is it really patient specific?
I'd say the thing we see most consistently is the quad strength goal. We do a really good job of trying to not slow down range of motion. I mean, I think we're pretty aggressive, as Dr. Benner described, with his fixation technique that he uses for these when he does surgery. So we're not put in a corner where we can't work on motion for so long that it's a super difficult thing to get back. I mean, that's a tremendous benefit to work with surgeons who allow us to work on range of motion so aggressively. So I don't normally see a slowdown coming from a loss of motion. It's really more from the return of the quad strength.
Now, I'm glad you mentioned the surgery piece. So this question is really for both you guys. In the previous episodes, Dr. Benner, you had mentioned that over the past 5 or 10 years, you feel like the fixation, especially with the distalization, has been improved and you're getting better fixation. So the question would be, based on that, would you anticipate seeing patients get back faster because of that? Or would you see patients maybe go a little bit faster in the early going because of that better fixation? Or is that just to prevent re-injury? Can you both speak to what that fixation looks like and how that may affect rehab?
Yeah, early on in Dr. Shelbourne's experience, I think he was doing one screw for tibial tubercle osteotomies, and that's what he did back in his fellowship in the early 80s. And then he started having some trouble with healing at the distal part of the osteotomy, so then he went to 2 screws, and I think that's what a lot of people use for fixation. People are really hesitant to put a plate on the front of the tibial tubercle because they worry about hardware prominence, and especially in thinner athletes, because there's not much soft tissue over the tibial tubercle anteriorly, and I don't particularly want to put it there either. However, I don't find that to be as big of an issue as people might think it is. So I follow Dr. Shelbourne's lead on using a 1/3 tubular plate on the anterior portion of the tibial tubercle in medializations and triots, and then using a T-plate from a small fracture repair set for distalizations. For me, I was always using just position screws, just putting the screws in place without really getting as good a compression. I was just kind of holding it down with my hand and then putting screws in. And then I started to use lag screws like I would in a fracture, where I over drilled the proximal cortex of the tibial tubercle to allow the screw to slide through the actual piece, the tibial tubercle piece, and compress it against the rest of the bone. So I feel like once I started using lag screw technique, I've been getting better fixation, and that has led to a difference in people feeling like they can a little bit more aggressively move their leg and even lift their leg on the day of surgery, or even in the early time after surgery, that they can actually lift their leg when it's really just held together by a plate and screws. I also make some of this is because I do arthroplasty surgery as well. In arthroplasty surgery, when we're talking about increasing exposure but doing tibial tubercle osteotomies, one of the important technical notes is to use a longer and a little bit thicker osteotomy. So I use an osteotomy that's about 1 centimeter thick and is about 6 centimeters long. It's a pretty big osteotomy. And for sports medicine surgeons who aren't used to making big incisions and using a lot of metal, who are doing a lot of things arthroscopically, I think maybe they feel like they want to stay away from something like that. But now, having done it that way for a while, I think the plate fixation is really important, and that lag screw technique to get increased fixation with a longer, thicker osteotomy has been more robust fixation, has made me more apt to be able to push a little bit harder on range of motion. And I do feel like that's made a difference in patients getting back range of motion and early leg control.
Yeah, I would agree. I would agree with that on the rehab side of things. I mean, we have had patients in the past, especially with distalizations, who we used to let them go to tolerance, and they don't always feel if they're going too far. So we would take some X-rays at 2 weeks post-op, and all of a sudden we'd see that their tibial tubercle is no longer under the hardware. They pulled the tubercle out from underneath, and they didn't even know when that happened. So that's caused us to kind of slow those patients down a little bit further. But then I think the change in fixation that Dr. Benner's brought to the table has really allowed us to feel comfortable with what we're doing on the rehab side and not have to immobilize these patients.
So, Bill, in a more general sense, what would you say the biggest difference is when it comes to the rehab process for those 3 surgeries that can be performed, including the soft tissue realignment of the medial lubrication, the triot, and the distalization?
Yeah, the biggest difference is timing. The concepts are all the same. The patients come in normally with full extension, limited flexion, limited leg control, and a fusion. The biggest difference timing-wise would be the soft tissue procedures can discharge the immobilizer quicker. They have better leg control quicker. They get flexion back faster. They can get their strength back and return to sports quicker. The triot and the distalization, those procedures where osteotomies or the bones involved, we just have to slow down that initial time frame, which then delays the recovery of the secondary things: flexion, leg control, leg strength, and return to sport. So, and those are kind of the differences between those 3 different procedures is really more timing than anything.
So in closing things up here, Bill, what do you think are your final take-home messages as you've been able to use your experience over more than a decade here at Shelbourne Knee Center treating a lot of these patients? What's the take-home messages that you really want everybody that's listening to have?
Yeah, so I was thinking about this over my time that I've been in the clinic. I was there partly when this was being developed, and I've just learned so much over the time that I've taken care of these patients and seen these patients with you, Dr. Benner, Dr. Shelbourne, in the clinic, is that a patella dislocation is not as common an injury as people typically think. It's not something that you have seen over and over again. Certainly in our hands, where we're seeing knees only, it's still only about 10% of our volume, which is relatively low. The history, exam, the x-ray findings, those are all different from other types of knee injuries. And it's helped us develop our treatment algorithm, including 3 different kinds of surgeries to take care of these patella dislocations. It's really not a one-size-fits-all treatment plan. And I think that's the take-home message is, indications for non-operative treatment, and then if it's surgical treatment, determining which of those 3 surgeries that we have developed to take care of that patient's problem specifically, and the implication that has on their rehabilitation. So it really turns into a much more customized way to take care of that patient's specific patella dislocation, and it's definitely not a one-size-fits-all.
With that customization approach, I think it just highlights how important it is to have a good relationship between the surgeon and the physical therapy staff. I would feel very, very uncomfortable doing any of these surgeries and then sending them to an outside therapist that I didn't know and not having a great open line of communication. These patients, we have a lot more contact with our therapy staff, even in office, that we see every day than ACLs even, or than other types of scopes and things that we do pretty often. A lot of those things are pretty standard and straightforward, and there is more of a one-size-fits-all approach when it comes to ACL rehabilitation and scope rehabilitation, as opposed to the patellofemoral dislocations. Like you said, everyone's a little bit different. Everyone needs to be able to understand the theory behind why we did one surgery versus another, how far we can push them based on what we found in surgery, how far we can progress them based on whether or not they're tolerating it. Sometimes I'll tell you all to only move them to 70 or 80 degrees because that's what we got in clinic, in the operating room. And then you'll come back and say, hey, they're getting to 70 or 80 easy. They don't feel like they're having any tension on that fixation at all. Their x-ray looks good. Can I push them another 10, 15 degrees? And the answer is usually yes. But if we don't have that back and forth communication, that open contact, I think it would be much more difficult to take care of this population in particular.
Yeah, and I can echo that from my side. If I'm seeing patients from a doctor or a surgeon who did a patellar realignment, and I have no background on that surgery, that patient, their x-rays, the guidelines, it would be incredibly difficult to confidently take care of that patient postoperatively. So I agree with you 100% on the collaborative effort on taking care of these patients, not only from the beginning, but the postoperative x-rays, knowing what you got in surgery, knowing what we're doing with them in therapy. I think it's really the best way to go.
Excellent. So, Bill, just thank you again for coming on here. I know this is the second time we've had you, and you did excellent the first time, and I think everybody got a good insight into the rehab after ACL reconstruction for that one. So I think this one's going to be the same case. So I appreciate you being on here again.
Yeah, thanks so much for having me, and I look forward to next time.
Hit us up on our social media if you'd like to keep in touch with us on Twitter and Instagram. You can find us at the SKC Podcast. We have a Facebook and YouTube Facebook page and a YouTube channel as well, or you can email us at the skcpodcast@gmail.com. You can find the Shelbourne Knee Center podcast wherever you get your podcasts on all major podcast networks. Also, if you'd leave us a comment and or a review, we would appreciate that as well for others that come behind you. Thanks for listening to today's episode, and we'll see you again next week.